Welcome back. In this video, we're going to be thinking a little bit about febrile children. You might wonder why we need to have a specific talk about this. Febrile human beings or febrile human beings? Well, there's really three reasons for this. Firstly, the younger you are, the harder it is to assess you. Therefore, it would be madness for me to see a 25-year-old patient who presents with dysuria and diagnose them with meningitis. However, a 2-week-old baby can't tell me whether they've got a headache or whether it hurts to go for a wee. And therefore, a febrile illness in a small child is harder to diagnose. It's harder to diagnose in terms of the history, for the reasons I've explained. It's harder to diagnose from the examination because the signs of a febrile illness may be harder to elicit in a small baby who doesn't want to be examined, or a toddler who's miserable and cross and crying and won't let you examine them properly. The process of doing investigations is going to be more challenging, and therefore the differential diagnosis is harder to work your way through just because it's practically harder to assess children. Secondly, the differential diagnosis changes. So the differential diagnosis of a 2-hour-old baby compared with a 2-year-old child compared with a 12-year-old child is going to be very different. And so we have to understand that differential diagnosis and how it might present if we're going to see these children. Thirdly, we're seeing children who may have a serious illness that then has lifelong consequences if we miss it. And the specific example here is urinary tract infections. Pediatricians and doctors and clinicians seeing children who are acutely unwell in the first few years of life are obsessed with UTIs. We worry about UTIs because they're hard to diagnose in terms of examining the patient and taking a history. Getting the urine off the child is difficult. They can be related to underlying congenital kidney drainage problems, and they can cause kidney scarring and make children extremely unwell, both in the short term, but leave them with long-term damage. And so what we need to think about when we're thinking about the child who's got a fever, particularly under the age of 5, is how do we have a structured approach to thinking about this? The first thing to say is we have to have a structured approach that is different for different ages. So when we're thinking about neonatal sepsis, we have a very different approach to the rest of life because there will be some infections, such as group B strep sepsis or listeriosis, that are particularly manifest in the first few weeks of life and become less important as they get older. We then have to have a very rigorous approach to children really under the age of 6 months, because they can present with very subtle changes and have bacterial meningitis or a UTI or a septic arthritis. And we therefore have to also have a structured approach to the child under 5 so that we can think about the important differential and think about what might be presenting in this child, mindful of the fact that almost certainly the vast majority of febrile children we see will have self-limiting viral illnesses, and what they don't need is huge numbers of tests and investigations and interventions and treatments, when actually what they need is a bit of TLC and to go home with some paracetamol. Our job is to make sure that we diagnose and treat the life-threatening, serious, and important illness, that we have a structured approach to how we assess children so that we can send the right children home, and we can send them home safely with appropriate red flags and safety netting so that they return if and when they need to do so. And this is the key to managing acutely unwell children for any reason, but it's particularly important in febrile children where we see so many febrile children, many of whom are not unwell. I'd like to think of the causes of inflammation in a human being from a starting point. Inflammation of any organ will cause heat, pain, redness, swelling, and loss of function. And therefore, any inflammation can cause raise in temperature, either locally, such as a arthritis, or systemically with a child presenting with a fever. Therefore, that child, has probably got an infection, but we have to remember that there are other causes of high fevers, particularly when we might think about autoimmune conditions, or very rarely we might think about endocrine problems or cancerous problems such as lymphoma. The vast majority of our work is going to be infectious, but there are going to be children who present with an autoimmune condition, and we've known about a condition called Kawasaki's disease for many years, and it is an important part of our differential because it is so hard to diagnose, so easy to miss, and so important in terms of long-term complications. Similarly, in the post-COVID area, we saw children presenting with something called PIMS-TS, which was an inflammatory condition after COVID that we need to be aware of as clinicians. For the rest of this talk, however, I'm going to concentrate on febrile illnesses secondary to infection. And what I'd like you to do is I'd like you to ask yourself two questions. Firstly, what sort of germ might this be? And second of all, where did it start? We would divide illnesses up into bacterial, viral, and then we will see other infections such as fungal or spirochetes or protozoal infections. But the majority of our work is going to be bacterial or viral. Most of the febrile children we see have got febrile illnesses secondary to viral infections, some of which are serious, but most of which are self-limiting and not serious. We will, however, see a small number of children with significant bacterial infections. And these are the children that we need to make sure that we don't miss, because obviously if we have a child with a serious bacterial infection and don't give them antibiotics when antibiotics would change outcome, then that is not good medicine. So then this leads on to the second question is, where did it start? Obviously, there are going to be some things that are easier to examine. The skin, the soft tissue, these are things that we have to think about and examine thoroughly. We can look at the breathing rate and work of breathing, and we can do some form of clinical assessment of the chest in terms of listening to the chest, or maybe doing x-rays. Other things are harder to examine. For instance, the urinary tract infection that I've already mentioned. Do they have a kidney infection? Do they have a bladder infection? These are going to be harder to diagnose, and that's why we'll often try and get a urine in any febrile child. As I've already mentioned, you have to be able to examine the ear, nose, and throat of a child. And this is another important place where we might see infections and be able to diagnose a tonsillitis or a nasty ear infection. If we're trying to think about central nervous infection, this can be harder to diagnose. In small babies with an open fontanelle, we should always feel the fontanelle, and a tense, bulging fontanelle is a very worrying sign, as is a child who's very lethargic or got any focal neurological signs or doesn't seem to be interacting normally or has reduced consciousness or seizures, as I will discuss in a later video. And so what I want you to do when you go and see a febrile child under the age of 5 is try and think very hard about your structured approach. Your structured approach is always going to start with an A, B, C, D, E approach. You're going to always start with the airway and work your way through this. But as you take your focus history, I want you to be trying to think, what's the background to this child? What led up to this illness? Is this part of a longer term recurrent or chronic problem? Or is this a one-off acute illness? How quickly has this illness evolved? Are there features that might suggest a viral infection or a bacterial infection? Or does this seem like a more unusual infection? And then does the history and the examination suggest a particular organ or focus for infection that might help us in terms of thinking about the diagnosis and treatment? Finally, we have to put this all together in terms of how unwell is this child? Is this child septic and requiring emergency resuscitation and emergency testing, admission, and treatment? Or is this a child that we might worry a little bit about, do some tests, maybe observe for a few hours and see how things go? Or is this a child that we're far more reassured about because we've got a thorough history, a thorough examination? We believe we understand that this is a viral upper respiratory tract infection. We've got the signs, we've got the symptoms, and we're happy that we can make this diagnosis and advise the parents accordingly with the appropriate red flags, with the appropriate advice and the appropriate leaflet from Wessex Healthier Together. Please make sure that by the end of the session, you have gone onto the website, had a very thorough look at the Wessex Healthier Together information about febrile illnesses, but also acquainted yourself with what other information is available. There is a vast range of information available both for parents and carers, but also for clinicians. And for you as a pediatric student just starting off in pediatrics, the strongest advice I can give you is to familiarize yourself with the information on Wessex Healthier Together, both in terms of the basic information and the traffic light system and how that information is conveyed both to clinicians and to families. I think if you are familiar with the Wessex Healthier Together pathways, then this is an incredibly helpful start. For clinicians who are dealing with patients who are more unwell, we have two other really good websites that I need you to be familiar with. The Peer Network is the local pediatric guidelines network. And for very sick and unwell child, we have the Southampton and Oxford Retrieval Team, the SORT guidelines for acutely unwell children. This also has the SONNET, which is the neonatal arm of these guidelines. You don't necessarily have to know any of these guidelines, but it's important that you know where to find information, both the more general information on Wessex Healthier Together, specific guidelines on Peer Network, and then the guidelines for the very severely acutely ill child on the SORT guidelines. In terms of other websites that are useful to you, I would recommend that you spend a little bit of time looking at the BNF for children in terms of prescribing, and that you've also had a look at Microguide and the Southampton pediatric version of Microguide in terms of prescribing antibiotics. That's particularly relevant for this session, and I would expect any student who's going to be a clinician working with children to be able to access all 5 of these websites and use them as a way of delivering good, consistent healthcare. In this video, I hope you've started to think about your structured approach to a febrile child, trying to triage them into very sick children who need urgent resuscitation on the basis of their ABCDE assessment. Thinking about children who are maybe less sick, but who do need a bit of thinking about, particularly for the organ systems that we can't examine so readily, particularly the urinary tract. And then the children that we're far more relaxed about, that we might be able to send home with safety netting. How we think about the particular sorts of organisms that might be affecting the child's health, how we think about how unwell the child is, starting from a particular focus and then working its way through. And then finally, not forgetting that not all fevers are infective and that there are conditions such as Kawasaki's, PIMS-TS, and very rare conditions of the hormones or conditions such as lymphoma that might cause high fevers.